Okay, so once again, good evening everyone. Sorry for the slight delay. I was a little busy with some patients. Okay, anyhow, so today we are going to have a discussion on myofunctional appliances. I have basically divided this lecture into two parts, part 1, and the next part will take up in the next session. Okay, so myself, Dr. Rijul Agarwal, I am an orthodontist and a DAMS orthodontic faculty as well. Okay, so beginning with the session. So in continuation with our last lecture on orthopedic appliances, as we all know that a disproportion in the size or position of the jaw results in the skeletal discrepancy, which can be either in the sagittal, coronal or transverse plane. So the three approaches towards the management of this skeletal problem are through growth modification, camouflage option or surgical. Surgical option we've already discussed in the orthosurgical management. Camouflage means to hide the existing skeletal problem through dental correction. That is, camouflage is to hide the problem. We are not going to correct the skeletal problem, we are just going to hide. And next comes the growth modification. So in growth or modification we have orthopedic appliances and myofunctional appliances. So these are the two ways of growth modification. Orthopedic appliances comes के अंदर आते हैं headgear, face mask, chin cup, which I already discussed in the last class. And now today we are going to discuss about myofunctional appliances. So beginning with the introduction, so the myofunctional therapy, the term was coined by Lister in the year 1934. This is the same person after which we study the Lister classification of malocclusion. Rogers is considered as the father of myofunctional therapy. In the 3 M's, the term 3 M's, that is muscle, malformation and malocclusion, was coined by Graeber. So what did Rogers suggested was that he suggested the use of muscle exercises as an adjunct to mechanical correction of malocclusion. So from our discussion on functional matrix theory, we know that the form follows function, that is the soft tissue matrix influences the hard tissue or the surrounding dental tissue structure. So if we can influence or manipulate the hard soft tissue component, that is the muscles, we can correct the underlying dental malocclusion. So what he said was that the role of muscle imbalance in the etiology of malocclusion, and pictured the muscle environment of teeth as the living orthodontic appliance. Okay, so what he meant to say that the underlying dental malocclusion is the result of muscle imbalance. That is, the underlying skeletal malocclusion, be it class 2, class 3 malocclusion, is the result of surrounding soft tissue imbalance, which results in this deformity. Okay, so if we correct this soft tissue or the muscle imbalance, we can correct this underlying skeletal deformity. So coming up to the next scientist, that is Norman William Kingsley. He introduced the vulcanite inclined plane for jumping the bite. So these are the few names of the scientists important from your exam point of view. So beginning with the classification of myofunctional appliance, first classification by Profit, in which he divided into 4 classes, that is teeth-borne passive appliances, teeth-borne active appliances, tissue-borne and hybrid appliances. So what do you mean by active and passive? Passive नाम में ही है कि passive, that is they exert no intrinsic force or they have no force generating capacity and simply depend upon the stretch of the soft tissue and the surrounding muscle for their action. इसके अंदर आते हैं हमारे activator, binator, twin block and Herbst appliance. Herbst appliance is a fixed functional appliance. Next is a teeth-borne active appliance. Active मतलब जो actively force exert करेगा. सो इन्हीं अप्लाइंसेस में अगर हम कोई ऐसा कंपोनेंट डाल दें जो एक्टिव फोर्स एक्सर्ट करने लगे ऑन द dental tissue, that is the teeth, then it becomes the teeth borne active appliances. Examples are modified activator, bionator, kinator, Bimler's appliance, or elastic open activator. Third classification is the tissue borne appliance, that is the Frankel appliance. Most commonly asked question in your exam as well, which is a tissue borne appliance, or all of the following are tooth borne except. So just remember that Frankel is a tissue borne appliance, how we're going to discuss when we do Frankel in upcoming slides. And lastly is the hybrid. Hybrid means which is a combination of both teeth and tissue borne. So they are composed of components that are common to functional appliance but are combined for our specific need, and they are mostly used in the correction of jaw asymmetry. So hybrid ka image is like this. So it has both tissue component as well as a tooth borne component. So they are basically modified appliances, modified specifically according to our need. So what from exam point of view, what you need to know is that they are mostly used for the correction of jaw asymmetry, and this is their example image. Next classification is divided into three types, that is removable, semi-fixed and fixed. रिमूवल में आ जाते हैं हमारे एक्टिवेटर, बायोनेटर, फ्रैंकल. सेमी फिक्स्ड में आ जाते हैं डेनहोल्ट्स अप्लायंस एंड बास अप्लायंस. डेनहोल्ट्स इज अ नेम ऑफ लिप बम्पर विच इज गिवन इन अपर आर्च. एंड लास्टली द फिक्स फंक्शनल अप्लायंस, जिसमें आ जाते हैं हमारे हर्ब्स अप्लायंस, मारा अप्लायंस, जैस्पर जंपर एंड चोरो जंपर अप्लायंसेस. Next classification is divided into groups, that is group A, B and C. Group A is totally tooth supported appliances. Group B is tooth and tissue supported, and group is totally tissue, that is vestibular position appliance. So tooth supported में आ जाते हैं हमारे Catalan's appliance, inclined plane. Tooth and tissue में आ जाते हैं activator, bionator and fin block, and group C is vestibular position appliance. Again a very important classification from your exam point of view. All of the following are examples of group C appliances except. All of the following are examples of group B except. और latest जो INI pattern के according match the following as well. Okay, so again an important classification table. Moving ahead towards the indications and contraindications of functional appliance therapy. So first patient indication is growing patients with a positive VTO. VTO is visual treatment objective. So what is a VTO first? VTO is the first criteria for the selection of case selection for any functional appliance therapy. So what we do, इसके नाम में है, that is a visually treatment objective. That is through our visual or naked eye or through a clinical examination we are able to achieve the desired treatment objective or not. Then only we begin the case for functional appliance therapy or not. So how do we classify a patient as VTO positive or negative is if on advancement we clinically we ask the patient to move his lower jaw forward, and if for correction of overjet, if the profile of the patient improves, then we consider that the patient is a VTO positive. That is, the profile of the patient has improved on clinical advancement. Okay, and if the profile does not improve or worsens on voluntary forward positioning of the lower jaw, then the patient is not selected or is considered as a negative VTO patient. So for that patient, giving a functional appliance therapy is of no use. There is some other skeletal deformity, we have to direct our approach towards that. So first, growing patients with a positive VTO. Contraindication will be a non-growing patient. Next, a well-aligned dentition. Okay, and a contraindication is a crowded dentition. Why? Because a crowded dentition does not permit us to advance the mandible forward. Third indication, proclined maxillary anterior and upright mandibular teeth. Contraindication is proclined mandibular anterior teeth, a very important contraindication. Why? Because the negative or drawback of a functional appliance therapy is that it leads to proclination of the lower anteriors. Why? Because of the positive or the forward vector component, the class 2 component on the lower anteriors, leading to the proclination of mandibular anterior teeth. और अगर ऑलरेडी वो प्रोक्लाइंड है और उसमें हमने फंक्शनल अप्लायंस थेरेपी दे दी, it will lead to worsening of the dental malocclusion. Okay, so a very important contraindication. Next, a normal saddle angle. So what is a saddle angle? Saddle angle is the angle in the cephalogram denoted by the nasion, sella and articulae. Okay, so why a normal saddle angle? Because if the saddle angle is increased, the mandible की जो position होगी, mandible position would be posterior with respect to the cranial base. With respect to the cranial base, the mandible position would be posterior. So अगर एक posteriorly position mandible को आगे लाना will be very difficult through a functional appliance therapy. The aim of the functional appliance therapy is to increase the length of the mandible, not to alter the position of the mandible. मैंडिबल जिस पोजीशन पे ग्लिनॉइड फोसा में है, हम लेंथ बढ़ाते हैं मैंडिबल की, नॉट ऑल्टर द पोजीशन ऑफ द मैंडिबल विद रिस्पेक्ट टू द क्रेनियल बेस. ओके, सो अगेन अ वेरी इंपॉर्टेंट कॉन्ट्राइंडिकेशन. नेक्स्ट, एन एक्यूट गोनियन एंगल is an indication. Horizontal growth pattern. Increase, that is a vertical growth gonial angle. Increased gonial angle means a vertical directed or vertical growth pattern of the patient. अगर vertical growth pattern है patient का, तो प्रोफाइल एडवांसमेंट पे फर्दर वर्सन हो जाएगी. ओके, so it's again a contraindication for functional appliance therapy. Next is class 2 skeletal base with retrognathic mandible. Okay, and a class 2 skeletal with prognathic maxilla is not a indication of function. इस केस में हमें जाना पड़ेगा orthopedic appliance, that is a head care. Again, horizontal and vertical I've already explained. Low FMA with tendency towards deep bite, same cheese. Decrease LAFA, that is lower anterior facial height and convergent jaws. Same चीज को अलग अलग वर्ड्स में लिखा है. Now why I have written or summarized this indications and contraindications in a table form? आपका exam is a MCQ based exam, not a theoretical exam. So why these indications are important for your exam MCQ? Because exam में आपको एक बड़ा सा पैराग्राफ देते हैं जिसमें a child of this much age reported to your orthodontic clinic on cephalogram examination या उसकी readings, the gonian angle is this. What will be your advice to the such patient or how will you treat such patient? तो उसमें options में आपको twin block, none of the above ऐसे करके options देते हैं. Okay, that's why understanding these indications and contraindications becomes important. You don't have to write a theoretical exam, you have to write a MCQ based exam. और उसमें MCQs आपके clinical scenario based ऐसे आते हैं. The upcoming INI exam in November is a clear example of how a clear easy questions को in a form of long paragraphs they complicate, thinking कि students don't get panic कि इतना बड़ा paragraph है कुछ complicated होगा. If you read first few lines में ही आपको आपका आंसर मिल जाता है. ओके, सो अगर इतना दे रहा है तो एग्जामिनर का पॉइंट ऑफ व्यू यही है कि वो जानना चाह रहे हैं वेदर यू नो कि ये पेशेंट इज इंडिकेटेड फॉर फंक्शनल अप्लायंस थेरेपी और नॉट. ओके, दे वोंट आस्क यू कि भाई कौन सा ट्विन ब्लॉक एक्टिवेटर क्या दोगे. फर्स्ट इज thing for you to know is whether the patient or a child is indicated or a good candidate for functional appliance therapy or not. Generally CMI staging, pubertal growth spurt के पास है, okay, anything, the words like these frequently pop up in the exam. Okay, so moving ahead, this was the visual treatment objective. Okay, so another table not important from exam, just a summary of the components of a function appliance. Okay, not necessary कि हर appliance में ये सारे components होंगे, कुछ में हो सकता है कुछ में नहीं. So it's just a summary for your components of function appliances. So beginning with the appliance, that is the first is the bite plane. Recent exam INI नीट सब में एंटीरियर बाइट प्लेन पे बहुत क्वेश्चंस आए हैं. ओके, सो व्हाट इज बाइट प्लेन? बाइट प्लेन आर ऑफ टू टाइप्स, दैट इज एंटीरियर या पोस्टीरियर. या तो हम एंटीरियर में दे सकते हैं या पोस्टीरियर में, जहाँ देंगे उसका यूज बदल जाएगा. सो एंटीरियर बाइट प्लेन इज यूज्ड फॉर द करेक्शन ऑफ deep bite, and posterior bite plane is used for the correction of anterior cross bite. Okay, so how does the posterior and anterior cross bite plane act? We'll explain it with the help of a diagram. So supposedly these are the teeth in occlusion. The upper teeth is in crossbite with respect to the lower teeth. Now you have to move this teeth forward, but ये lower incisor का edge इसको ऐसा नहीं करने देगा. So what do we need is to raise the bite to a bite plane so that we are able to jump the bite. So this is the function of posterior bite plane. That is, it creates gap in the anterior region for us to procline or correct the cross bite in the anterior teeth. Okay, similarly anterior bite plane is used for the correction of deep bite. How? So this is how the anterior bite plane. So our image in which the anterior bite plane is present, it causes separation in the occlusion of the posterior teeth. तो जब posterior teeth के occlusion में separation होगा तो what will happen? The physiological eruption of teeth which continuously occur. So when the patient chews, these teeth will erupt, leading to the correction of anterior teeth bite. Okay, so this is the function of anterior bite plane. Okay, now we're going to discuss a few modifications of these bite planes, beginning with the first, that is the cat lens appliance. Okay, ये एंटीरियर और पोस्टीरियर बाइट प्लेन हमने दिया था अपर आर्च में. सो व्हाट इज अ कैट लेंस अप्लाइंस? सेम चीज अगर लोअर एंटीरियर इंक्लाइंड प्लेन दी दिया जाए, दैट इज ऑन द लोअर एंटीरियर टीथ. ओके, सो फर्स्ट इट इज सीमेंटेड ऑन द मैंडिबुलर इंसाइजर्स. यूज क्या है? इट इज यूज फॉर द करेक्शन ऑफ अपर एंटीरियर सिंगल टूथ क्रॉस बाइट दैट इज ऑफ recent origin. Each and every word of this highlighted line is very very important. That is, the inclined or the cat lens appliance is first of all is given on the lower anterior teeth. It is an inclined plane. Okay, it is cemented and इसका use क्या है? For the correction of upper anterior cross single tooth cross bite that is of recent origin. Okay, recent origin means the tooth has recently erupted or it's a developing cross bite. The tooth has not fully erupted, the crown or enamel has not fully erupted. So exam में आपको कैसे देंगे? Either they will give you this word of recent origin या they'll give you the age of the child. So most common they will give you between 7 to 8 years. 7 साल की उम्र में अपर सेंट्रल इंसाइजर इरप्ट करता है. It takes approximately 1 to 2 years for the full incisors to get erupted or the whole crown to get erupted inside the oral cavity. Okay, so just be careful. This is how the examiner wants you or asks you questions in the exam. Okay, नेक्स्ट जैसे मैंने बताया इट्स अ इंक्लाइन प्लेन, सो कितने एंगल पे इंक्लिनेशन है, इट इज ऑफ 45 डिग्री with respect to the maxillary occlusal plane. Okay, next is that this Catalan's appliance should not be used for more than 3 weeks. Why? As I've already told you that anterior bite plane causes eruption or extrusion of the posterior teeth. So जिन cases में ये demand ही नहीं थी, हम unnecessary उसको करा देंगे posterior teeth extrusion. So that is why it is not to be used for more than 3 weeks or 21 days. Okay, next इसी का modification, that is ये था fixed और cemented on the lower. अगर इसी का modification, that is a removable inclined plane with a bite rail, is known as Bruckel's appliance, used for correction of open bite. So ये है image Bruckel's appliance की. Okay, another a colored image of Bruckel's appliance. It's a removable anterior bite plane. So this is how it leads to the correction of anterior single tooth cross bite. This inclined angle, okay, causes or acts as a forward vector on the crown of teeth. So it will lead to tilting or the labial inclination of the upper teeth, leading to the correction of crossbite. Forward vector. Okay, next is a tongue blade therapy. It is used for a developing anterior single tooth crossbite. Okay, अगर developed है या fully erupted है या fully erupted matured crown है, तो उस केस में हमें जाना पड़ेगा through fixed appliance therapy, that is through our wires and bracket. It won't get corrected through such tongue blade or Catalan's appliance. So just be careful of the word developing, recent origin or the age in the question. France. Okay. Next modification, that is a Sved's bite plane. It is a modified form of anterior inclined bite plane where the bite plane extends over the incisal edges of the upper anterior teeth. That is from posterior to the posterior, from one right to left side, it covers all the teeth. Okay, इसका function क्या है? First of all, it's an anterior inclined plane on the upper arch. So how it will act? It will act by lower anteriors को lock in the forward position. अगेन इस डायग्राम पे आ जाते हैं. अगर ये ऐसे इंक्लाइन के फॉर्म में होगा तो व्हाट विल हैपन, द लोअर एंटीरियर टीथ विल गेट लॉक्ड बिकॉज ऑफ दिस इंक्लिनेशन, दे वोंट बी एबल टू गो बैक. सो इसका फ़ायदा क्या है, अगर हम लोअर मैंडिबल को फॉरवर्ड ला के इस पोजिशन पे लॉक कर देंगे, वी विल बी एबल टू करेक्ट क्लास 2 स्केलेटल मालऑक्लूजन. ओके, additional advantage क्या है, it reinforces the anchorage. How? So जैसा मैंने बताया, it will give a forward or a mesial movement on the lower teeth, and at the same time it will have a distal force on the upper jaw. So अगर distal force upper पे act कर रही है, it will lead to the posterior movement of the upper teeth, thus reinforcing our anchorage. Okay, clear? So this is the Sved's bite plane. I have उसकी image. Next is the posterior bite plane. That is the acrylic glice plate which covers the occlusal surface of the posterior teeth. I've already told you how it acts. It is used for the correction of anterior crossbite, and it should be wide enough to contact the buccal and lingual cusp of the opposing teeth. Okay, अगर कोई भी cusp uncovered रह जाएगा, it will lead to that eruption or extrusion of that teeth. So it's necessary that the posterior bite plane should cover the occlusal surface of all the teeth for correction of anterior crossbite. So posterior bite plane की वजह से anterior crossbite नहीं correct होगी, we have to give certain fixed appliance in the anterior region. This is just to raise the bite. Okay, so be careful posterior bite plane is just to raise the bite for the anterior cross bite correction. उसकी वजह से करेक्ट नहीं होगी, करेक्शन के लिए we have to give appliance in the anterior teeth as well. Okay, so till now we have been talking about the cross bite. So the cross bite की classification होती है which I have tried to give in the form of question. So what is decomplex cross bite? So anterior cross bite can be divided into three types, that is simple, complex and pseudo. Simple, when there is sufficient space within the arches available. Complex, when some crowding exists. Hence the question, complex anterior cross bite is when there is no space for correction of cross bite, there is presence of crowding in the anterior teeth. And pseudo class 3 or pseudo cross bite is a situation in which is not true class 3. It is due to forward shift of mandible due to the presence of occlusal prematurity that a cross bite is happening. It is not a true class 3. The patient or habitually presents his mandible or forces his mandible in the forward position. Why? Because of the presence of any occlusal prematurity. Is known as pseudo class 3. Again a question, anterior bite plane is given for the correction of cross bite, deep bite, open bite or scissor bite. So it's used for the correction of deep bite. So how much thickness should be there of the anterior bite plane? It should be thick to sufficiently open the bite in the premolar region by 4 to 5 mm or 1 to 2 mm in the posterior teeth, not more than that. If it's more than that, again a question for exam, what are the side effects of the anterior bite plane? It can lead to the development of lateral tongue thrust. An important side effect or drawback of giving a high anterior bite plane, जब posteriorly space open होगी, tongue has a tendency to protrude through that space. Next appliance is a vestibular screen. Very easy to understand. It is used for the correction of habits, that is mouth breathing, used for the correction of mild distal occlusion, muscle exercise and mild anterior proclination. How? So the vestibular screen, it's constructed through acrylic, overextended. So what will happen, यहाँ पर ये overextended होगी, it will lead to the pulling off of the oral mucosa and the surrounding muscles which are attached to it. So जब ये pull होगी, so it can lead to muscle exercises. And how it will correct mild distal occlusion, that is mild class 2. जब ये pull होगी, so as we have already seen through functional matrix therapy, जब soft tissue pull होगा, अपने साथ hard tissue आगे लाएगा. So it can be used for correction of mild distal occlusions as well. And mild anterior proclination, ये vestibular screen continuously enforce देती रहेगी anterior teeth पे, and anterior proclination can be corrected, but of mild level. Mostly the vestibular screens are used for correction of mouth breathing and muscle exercise, muscle training. So the first vestibular screen was given by Newell in the year 1912. It acts by the mechanism of force elimination, how I have just told you. Next comes its modification. First is the Hodge modification, or the presence of metal ring. So what he did was, Hodge incorporated a metal ring like this in the anterior region. So how it helps, the patient continuously, the lips continuously suck on this metal ring. It will lead to the increase in lip length. Third modification is the cross modification of the double oral screen. Not only it helps in eliminating the force from the lip musculature, but the double oral screen or the screen on the inside helps to eliminate the force from the tongue as well. So abnormal tongue activity को भी कंट्रोल करने के लिए वी कैन गिव अ डबल ओरल स्क्रीन. दिस इज द इमेज. So what is the recommended wear time? It is recommended to wear at night time and 2 to 3 hours in a day. Okay. Next, again a question important for exam. During functional appliance treatment, with every mm of incisor tipping, there is loss of how much skeletal correction. So what does it mean? I've already told you. Functional appliance therapy से क्या होता है? The lower incisors teeth get proclined due to the mesializing action on the dental structure. So जितना लोअर एंटीरियर टीथ प्रोक्लाइन होंगे द ओवरजेट करेक्शन जो हम स्केलेटली या मैंडिबल एडवांस से कनेक्ट करना चाह रहे थे वो लोअर एंटीरियर टीथ प्रोक्लाइन करके खत्म कर दे. ओके, सो द क्वेश्चन इज विथ एवरी mm ऑफ इंसाइजर टिपिंग, मतलब 1 mm अगर इंसाइजर प्रोक्लाइन कर रहे हैं लोअर इंसाइजर्स, सो वी आर नॉट एबल टू करेक्ट 0.5 mm of skeletal correction is lost. 0.5 mm skeletal advancement is lost. So we have to design or find ways to prevent the proclination of the lower anteriors. How and how do we do it? It's not important for your exam or at a graduate level. For your exam you just have to know that lower functional appliance therapy से lower incisors procline होते हैं. That is a side effect or drawback of the functional appliance therapy. And कितना mm skeletal correction loss होता है for every mm of proclination of lower anteriors? That is 0.5. So next appliance is the activator. Okay, so the origin of activator, first, as I already told you, Norman Kingsley, he gave the term jumping of the bite. Okay, next came Hotz, that is he gave the term Vorbis plate for the correction of retrognathic mandibular deep bite or retrognathism with retroclined lower incisors. Pierre Robin gave the term monoblock appliance. So this is the activator appliance. It's a single block connected. The lower anterior blocks are connected in this anterior region. Okay, so this is the upper block, this is the lower block. Okay, and this is the anterior teeth. So how it's designed, the patient की एक हम wax bite record करते हैं in the forward position. So these are the dental tissue indentations और teeth indentation, और पेशेंट को इस पोजीशन पे बाइट करना है. एंड पेशेंट को जब ये अप्लायंस हम एक्रेलिक में फैब्रिकेट करके देते हैं, पेशेंट हैबिचुअली और कंटिन्यूसली बाइट इन दिस फॉरवर्ड पोजीशन. ओके, सो जब ये कंटिन्यूसली बाइट करेगा व्हाट विल हैपन, देयर विल बी विस्कोइलास्टिक स्ट्रेच इन द कॉन्डाइलर रीजन. रिमेंबर सर्वो सिस्टम थ्योरी. ओके, leading to the increase in the length of the mandible. Next comes Viggo Anderson. He coined the term biomechanical working retainer for this activator, and he was from Denmark. So he modified the simple Holly's retainer. So he was the first one who developed this activator appliance in this current original form. Okay, so how he developed, he more simply modified the Holly's retainer. So अगर हम इसको upper and lower block को अलग कर दे, it's simply a Holly's retainer. So upper and lower Holly's retainer joined together becomes a activator. Hoppel, another scientist work from Norway, gave the term activator. So that's why it is also known as Norwegian appliance. These all names are very important for your exam point of view. Okay, so Anderson Hoppel activator. So what are the indications? Same as for any functional appliance which we have discussed. Actively growing patients with a favorable growth pattern conditions like class 2 div 1 or div 2 malocclusion. So div 2 means retroclined incisors. So इस केस में हम advancement कैसे करेंगे? So first we have to correct the retroclination, then only we can advance the mandible. Okay, next is class 3 malocclusion. Similar, reverse overjet में भी we can give a class 3 activator. Class 1 open and deep bite cases as well. And for post-treatment retention after headgear therapy, जिसमें class 2 हमने correct कर लिया. Lastly, children with decreased facial height. What are the contraindications for activator? Crowded teeth with disharmony between tooth and jaw size. Crowding, as I already told you, will not help us in advancing. Patient with excessive lower facial height and proclined lower incisors. Cause cases of nasal stenosis. Already patient nose से breathe नहीं कर पा रहा है, mouth breather है, through obstruction in the nose, and we have given him an activator जिससे upper lower jaw पूरा बंद हो गया, तो patient won't be able to breathe at all. Lastly, a non-growing individual जिसमें functional appliance is absolutely contraindicated. So what is the philosophy or mechanism of action of activator? As I've already told you, by holding the mandible in the forward position, it leads to the stretch of the periosteum and the surrounding soft tissue. Force viscoelastic stretch from the condyle or the TMJ is transmitted to the periosteum, bones and the teeth. Okay, so what will happen? दो तरह के चेंजेस होंगे, मैक्सिला एंड मैंडिबल अलग अलग. मैंडिबल क्या करेगा? इट विल बी एडवांस्ड एंड मैक्सिला पे क्या होगा? एक रिस्ट्रेनिंग और डिस्टलाइजिंग इफेक्ट आएगा. सो इट विल हैव अ रिस्ट्रेनिंग इफेक्ट ऑन द ग्रोथ ऑफ द मैक्सिला एंड द मैक्सिलरी डेंटोएल्वुलर कॉम्प्लेक्स. along with there will be a stimulation in the growth of the mandible and the mandibular alveolar adaptation. Okay, तो इससे क्या होगा? The mandibular length will increase. Mandible length बढ़ेगी, class 2 correction हो जाए. It causes a favorable change in the temporomandibular joint. So what are the components of a activator appliance? It has a labial bow. Image में हमने देख लिया labial bow. Okay, can be made of 0.9 mm or 0.8 mm depending on the function or the requirement of our appliance. Okay, whether we want to retrocline or correct the proclination of the incisors or not. Next is a jack screw. It is optional, fitted to the maxillary arch if required for the expansion or not. Next is lastly is the acrylic portion. Okay, which is like upper and lower Holly's type coverage with interocclusion. Acrylic. Lastly is the back bite or wax record. So what it is used for? It is used for the intermaxillary record to relate the mandible to the maxilla. So purpose is to reposition the mandible in the forward direction as well as to open the bite vertically. So कितना mm advancement mandible का करना है is determined to this wax bite record from the patient, and based on this we fabricate the appliance. Okay, so for any other appliance moving forward, be it twin block, bionator, these wax bite records are very important. So what are the methods of recording the bite? There are two ways, through minimal vertical opening or moderate vertical opening. There are two components of any wax bite record. One is the vertical opening and next is the horizontal advancement. So both have certain limits. कितना स्ट्रेच कर सकते हैं? ऐसा नहीं है कि अगर हमारा 14-15 mm का ओवरजेट है तो हम उसको 12 mm एडवांस कर देंगे मैंडिबल को 1 go में, so as to achieve the desired 2 mm overjet. Okay, the soft tissue also has certain stretchable limits. जैसे हमने सर्जरी में डिस्ट्रैक्शन भी पढ़ा होगा. Every component of our body has certain limit. Okay, so कितना लिमिट है, कितना क्या है, we is depending on this way we require the wax bite. So first is the minimal vertical opening. Okay, so this was the original Anderson-Hoppe concept. जिसमें horizontal advancement is 3 mm distal to the most protrusive position. Most protrusive position का मतलब क्या होता है? पेशेंट को कहेंगे अपना मैंडिबल फ्रीली जितना आगे ला सकता है लाए, बी इट द पोजिशन जिसमें एंटीरियर टीथ क्रॉस बाइट में चला जाए. सपोजली ही इज एबल टू ब्रिंग द मैंडिबल फॉरवर्ड बाय 10 mm, so we'll advance the mandible 3 mm posterior to that, means 7 mm horizontal होगा, and vertical कितना होगा? बचा हुआ. So this sum of this vertical and horizontal component should be 10. That is known as the rule of 10 for recording a bite of functional appliance. that is the sum of the vertical plus horizontal advancement should be equal or less than 10 mm. It should not be more than that. So अगर हमने horizontal advancement 7 mm का किया तो vertical हमारा 3 होगा, horizontal हमने 6 किया तो vertical 4 या उससे कम हो, depending on that. Okay. Vivek is asking, sir, how synchondrosis activity is associated with functional appliance therapy. Let me complete this recording the byte, then I'll answer your question. Okay. If anyone has any other question, can mention in the chat section as well. Okay. So as we are discussing the methods of recording the byte. Okay. Rule of 10, that is the sum of the vertical plus horizontal advancement should be 10. So अगर हमारा horizontal 7 है तो vertical 3 रहेगा, depending on that कि हमारा केस में requirement क्या है और क्या हमें करना है अचीव. Okay, next is the moderate vertical opening. Similarly, horizontal 3 mm distal to the most protrusive and vertical should be approximately 4 mm beyond the rest position of the mandible. Okay. रेस्ट पोजिशन जिसमें फ्रीवे स्पेस इंक्लूडेड होती है तो 4 mm इट शुड बी बियॉन्ड दैट. इन्हीं वर्टिकल और हॉरिजॉन्टल कंपोनेंट के एडवांसमेंट के बेसिस पे देयर आर टू टाइप्स ऑफ एक्टिवेटर, दैट इज अ एच एक्टिवेटर एंड अ पी एक्टिवेटर. व्हाट इज अ एच एक्टिवेटर? एच मींस हॉरिजॉन्टल, मैक्सिमम सजाइटल और हॉरिजॉन्टल एंड मिनिमम वर्टिकल एडवांसमेंट. तो ये इंडिकेटेड होता है इन हॉरिजॉन्टल ग्रोथ पैटर्न पेशेंट्स. एंड नेक्स्ट इज द वी एक्टिवेटर जिसमें है हमारा मोर वर्टिकल एंड लेस हॉरिजॉन्टल. इट इज इंडिकेटेड इन वर्टिकल ग्रोथ पैटर्न पेशेंट. वाई? वर्टिकल ग्रोथ पैटर्न पेशेंट्स में होता क्या है, जनरली देयर इज एन एंटीरियर ओपन बाइट, द पोस्टीरियर टीथ आर इरप्टेड एक्सटर्नली. सो हम हाई कंस्ट्रक्शन या हाई वर्टिकल बाइट पे पेशेंट को एक्टिवेटर देते हैं. Why? Because it leads to, जब patient उस high block पे bite करेगा, it leads to intrusion of posterior teeth. Okay, that's why a vertical activator is indicated in vertical growth pattern patient. Why? Because it leads to the intrusion of posterior teeth. So total sagittal advancement should not be more than 70% of the total protrusive path. अगर यही चीज परसेंटेज में पूछे या mm में पूछे, 3 mm और 70%. Okay. Lastly, the construction bite without mandible forward positioning given in deep bite and open bite cases, and construction bite with opening and posterior position of the mandible is given in class 3 malocclusion cases. Easy to understand. जिसमें mandible forward है, हम पेशेंट का मैंडिबल रिट्रूस या पीछे ले जाके बाइट करने को कहेंगे फॉर करेक्शन ऑफ क्लास 3. ओके, सो दिस वाज द स्केलेटल एडवांसमेंट. नेक्स्ट कम्स द डेंटो-एल्वियोलर का इफेक्ट और द कंट्रोल ऑफ द टूथ इरप्शन. सो इट इज मोस्ट इफेक्टिव इफ यूज्ड इन अर्ली मिक्स्ड डेंटिशन स्टेज. सो व्हाट वी डू इज, अपार्ट फ्रॉम एडवांसमेंट वी डू ट्रिमिंग ऑफ द एक्रिलिक और द इंटरऑक्लूजल एक्रिलिक एज वेल, so as to settle the occlusion in the new class 1 position. So what is the trimming pattern which is important for exam point of view is, in the upper teeth we trim in the disto-occlusal pattern, and for the lower teeth mesio-occlusal trimming is there. So the upper teeth are like directed like this and lower like this to settle into a class 1 molar relation. So this is the trimming pattern for activator for settling the bite. This completes our activator. If anyone has any question can write, and otherwise I'll take up the question posted here. So the question is, how synchondrosis activity is associated with functional appliance therapy. So what are synchondrosis? Synchondrosis or the cranial base synchondrosis are the junctions or the overlapping junctions, not overlapping, are the junctions between the bones of the cranial base. Okay, so there are 4 important synchondroses we all know. Okay, so functional appliance therapy, Vivek, is used for the advancement of mandible. okay, or to increase the length of the mandible. ओके, सो फर्स्ट फंक्शनल अप्लायंस थेरेपी अगर हम एक्टिवेटर ट्विन ब्लॉक या इसके थ्रू कर रहे हैं फॉर एडवांसमेंट ऑफ द मैंडिबल और इंक्रीज द लेंथ ऑफ द मैंडिबल, इट विल हैव नो इफेक्ट ऑन द सिनकॉन्ड्रोसिस एक्टिविटी ऑफ द क्रेनियल बेस. ओके, या यही चीज़ अगर हम हेड गियर पे कर रहे हैं, हेड गियर के थ्रू मैक्सिलरी ग्रोथ या मैक्सिलरी बोन का डिस्टलाइजेशन या रिस्ट्रेनिंग कर रहे हैं, इट विल हैव अ नेगेटिव इफेक्ट ऑन द सिनकॉन्ड्रोसिस एक्टिविटी ऑफ द क्रेनियल बेस. ओके, क्यों? क्योंकि वो फोर्स जो डायरेक्ट हो रही है क्रेनियल बेस मैक्सिला के थ्रू, द फोर्स इज रिस्ट्रेनिंग द फॉरवर्ड और डाउनवर्ड फॉरवर्ड मूवमेंट ऑफ द मैक्सिला. एंड एज वी नो कि जो मैक्सिला की फॉरवर्ड मूवमेंट होती है, इट इज रिलेटेड टू इन टू वेज टू द फर्स्ट थ्रू इट्स इनवर्ड ग्रोथ एंड सेकेंड थ्रू द क्रेनियल बेस इनकॉन्वर्स. ओके, सो स्पेसिफिकली अगर पूछोगे तो हेड गियर के थ्रू इट हैज़ अ रिस्ट्रेनिंग इफेक्ट ऑन द क्रेनियल बेस सिनकॉन्ड्रोसिस और थ्रू हेड गियर एंड सिमिलरली थ्रू फेस मास्क. दैट इज़ वाई ऑर्थोपेडिक अप्लायंसेज में हमें इतना हाई लेवल ऑफ फोर्स चाहिए होता है, बिकॉज वी हैव टू रिस्ट्रेन और रीडायरेक्ट द ग्रोथ एंड दैट ग्रोथ इज एक्टिव ऑन द वेरियस सूचरल सिस्टम्स. सिमिलरली मायोफंक्शनल अप्लायंस का जो इफेक्ट होता है थ्रू डेंटल इफेक्ट ज़्यादा होता है and dentally through skeletal pass होता है. So it has no effect on the cranial base synchondrosis. I hope I am able to clear your doubt here. If any other doubt or any other question or query, you can write it or you can post it, tag us. We'll be happy to answer. Okay, so I think I'm clear with my explanation. So I'll end the session. We'll take up the remaining part of the myofunctional appliance in the next upcoming session, that is swim block, Frankel appliance and bionator, and fixed function appliances as well. So there are a lot more to discuss in these topics as well. In the limited allotted time, I can cover this much only. Okay. Still, if anyone has any doubt, you can always tag us and let us know, and we'll be able to help you out. Okay. So thank you and good night and all the best for your INA exam.